On to our next phase of the morning now, and it's going to be reflections from the brain community. And if there is time, we can have some questions from the audience as well. So please welcome to the floor Elena Becker-Barroso, who is Editor-in-Chief of the Lancet Neurology, Orla Galvin, Executive Director of the European Federation of Neurological Associations, Péter Kéri, President of GAMIAN-Europe, and Professor Boon, President of the European Academy of Neurology, and Professor Gorwood, past President of the European Psychiatric Association. So we have a full house, a full floor, and a little bit of musical chairs. So since you're sitting next to me, let's start with you. The floor is yours. You've got, you're on timer now, off you go.
So in a couple of minutes, because that's the challenge part of it. My main point as the past EPA President Psychiatric Association is to say that definitely it's a huge cost, the burden is high, but what is extremely important is that all what you do to treat mental disorders is cost saving. So for policymakers, it's very important to say that you're not going to invest and hoping that it's not to be too high cost. You're going to save money, but you have to be brave enough in order to get this kind of investment. And I would like to give 3 examples in the 3 minutes I have left. The first one is, for example, using mindfulness in kindergarten. Incredible. But these very young babies, as they increase their awareness, being able to focus on their attention on now, what happens yet, and then develop the way they are eliminating rumination, for example, might have a huge impact on their lifetime. And that's very simple. It's even not treatment. It can be done in the kindergarten. A little bit later, we have a huge worry about bullying. Kids are very tough, especially if you're a little bit different, language, culture, color, whatever. And these kind of things, if you try to avoid it, and we have now a very clever way to do that efficiently, you are reducing a lot the lifetime course of psychiatric disorders. And just for the very later aspect of what we can do in the global population of adults, there's been a study just published last week, which I think is really eye-opening. It's how, when you use B9 vitamin, it's not a treatment. There's no impact of that, because if you take too much, you eliminate your vitamin. But for those taking vitamin at least a couple of months, the rate of suicidal attempt is diminished by 2, odds ratio 0.5. So that's very easy, that's extremely cheap, and it's just a kind of example that a lot of things can be done in order to have huge impact if you're brave enough to invest.
Well, that was very concise. Thank you so much. Gosh, well, bravo to you. Just for those who may not know, B9 is also known as folic acid.
Folic acid, one of the core vitamins that we all use, and later on life, usually we have a little bit lower level, and then we have to take a little bit of more B9 vitamin.
Well, that is really interesting research indeed, and not obvious, I think, also. But of course, we know that food is medicine, so here we have an example of it. Now, Péter, I know you mentioned you would rather go last, but in fact, given what Tarun said earlier, it was very poignant to me, because in fact, if I may say, because you're a patient representative, you had thought the experts should go first and you should maybe speak last, but actually Tarun said very, very thoughtfully and poignantly that in fact it's bottom up. So your floor.
Thank you very much. In my country, people living with schizophrenia wake up now, and for me it's early as well, because I was diagnosed with schizophrenia when I was 43. And I think it is a very good example that we can work together with different stakeholders to create a new fruitful life for a person who had a new great fruitful life in the past. So I met psychologists, psychiatrists, researchers, psychosocial workers, everybody around. And I understood how collaboration can help people living with big mental incurable diseases to achieve a better life, what they deserve, what they had earlier, with cooperation. And as president of GAMIAN-Europe now, I really see gorgeous faces here working together with us at GAMIAN-Europe's house. Thank you very much for that. Because I truly believe that an organization like that can give a space for communication between all the stakeholders. Because I truly believe that the patient is in the center somewhere, but many aspects we have around us. One wants to cure me in that way, the other wants another way, and I don't understand sometimes why. Now I know. And if you collect all the voices from patients from all over the world, throughout Europe, and there's a safe space in Europe, like GAMIAN-Europe is, then we can be there where there's a research, where there's a question from WHO, for example, where we can collaborate with different organizations, with different aspects. And I truly believe that it can help back patients again, and we can understand how they heal better and how effectively they can heal.
Thank you, Péter. Elena.
So from where I stand, the most conspicuous aspect of this community is actually success. It's your enormous success. And I would like to reflect on that briefly, if you allow me, because as an editor, I've been the witness of the tremendous success of this field over the past 20 years. And it's truly remarkable. And I think that during this Brain Awareness Week, people should know how remarkable it is, right? So let me start with stroke, for instance. So the acute treatment of stroke has been revolutionized by the use of thrombectomy and thrombolysis. That means that a person with a stroke who will have died 20 years ago, today, if she presents to a hospital within a 6 hours window of symptoms onset, most likely she will survive. Not only that, the advances in recovery and rehabilitation are such that most likely she will survive with a good recovery. Now, the advances in prevention are also spectacular. So we know about the risk factors that can prevent stroke. We know about the medication and lifestyle changes that can prevent recurrent strokes. Advances in migraine and headache, spectacular, impressive accomplishments in treatment. Physicians now have monoclonal antibodies and small molecule drugs called GEPANs that prevent migraines, that can treat acute headache. These drugs all block the CGRP pathway in the trigeminal vascular system, and this discovery is phenomenal. Alzheimer's disease, a lot of misunderstanding in this field. People think that the field is stuck, that they are failing to succeed, farther from reality. Alzheimer's disease is now a biological diagnosis that physicians can do using biomarkers. Biomarkers like PET tracers in vivo, like CSF and plasma biomarkers that are cheap and are not invasive. Now, these discoveries have paved the way for disease-modifying clinical trials that are gonna stop and delay Alzheimer's disease. We already have a drug, lecanemab, that cleans the brain from plaques and actually delays cognitive decline by months. So if this is not truly remarkable, so explain to me what it is. Now, well, I could go on forever. Multiple sclerosis. I quote Stephen Hauser here. Nowadays, MS relapses can be completely and safely eliminated in most patients, and symptoms can be slowed. These breakthroughs represent a profound achievement of modern molecular medicine. That's it, of your work. Rare diseases, what could I say about the gene therapy in spinal muscular atrophy? This is a life-changing history. And finally, to just reflect on the bidirectional nature of clinical research and basic science, I would like to notice about the discovery of NMDA receptor encephalitis, which is an inflection point in our understanding of autoimmune disorders of the CNS, but also of the mechanisms of schizophrenia and psychosis. So in a nutshell, neuroscience can save lives and lead to better lives, and I hope that our politicians realize this as quickly as possible.
Thank you so much, Elena. It's so lovely to have some positivity and some optimism. I'm sure that's good for all of our brains. I'm sure Philip could tell me further. Over to you now. You're going to tell us, I'm sure, Professor Boon, something exciting.
Well, thank you very much, and thank you for having invited me. I'm talking about, I will briefly talk about neurology, and I'm very happy that I do not have to deal with all the successes of our fields and of everything that has been said here. It is indeed highly encouraging. However, I would like to focus a bit more on the future challenges, though. There is still a lot of work to be done. And you can always look at the glass of beer, we are in Belgium, half full or half empty. I'd like, and it has nothing to do with negativity, it has to do with where are the real challenges. A couple of them I'd just like to point out now and share with you. First of all, about neurology. There's many claims in the world of neuroscience saying, you know, we are so important, and if you're not careful, you immediately end up in a competition among diseases or fields or disease fields, and that is certainly not the issue. The issue truly is that based on very sound research, much of which has been published in your journals, neurological diseases are so prevalent, at least 1 in 3 people in Europe, and probably higher outside of Europe, have a neurological disease. So if I would ask you here in the audience, I will not, who has a neurological disorder, at least 1 in 3 people in this room would tell me, if they're honest, that they do have a neurological problem. So the burden is massive and it should not be questioned. We obviously always need better data, but I mean based on the data from the Seattle database, based on all the work that has been done, and based on the work that we also, as a group of European neurologists, we're basically representing 47,000 colleagues in Europe, we know how big the burden is, one thing. Secondly, brain health. This is an interesting topic. We've heard about it. Thank you for your very eloquent talk and helicopter view, providing us with the helicopter view, Taron, on this issue. I would still like to, and this is no negativity, it is just, I'm telling you just this with the purpose of trying to speak with one voice. There is no unified, generally accepted definition of brain health for the moment. Anything like, I mean, you have a problem with your heart, you go to the GP, he does an ECG, maybe draws some blood, and you get reassured or not reassured about your cardiac health. There is unfortunately for the moment no such thing as a brain kit that allows you to very quickly tell you my brain is healthy or not. We are not at that stage yet. The brain is a bit more complicated, as you eloquently pointed out so eloquently. I think this we should never forget. So brain health is one thing. We have an operational definition. We are using it. The neurological community has worked very hard to implement brain health in their strategic plans. We're working with IGAP. We are working with the epilepsy community to make this happen. What I believe is and I would like to point that out, the European Union is basically not so competent, quote unquote, on health issues. Health policies are mainly a matter of the national governments. People tend to forget that there was huge criticism towards the EU during the COVID crisis, but people forgot that it is the national governments who are responsible in the end, right? As far as we are now. So what are we doing on that? And we are using our national representatives in those 47 European nations to incite them to talk to their governments, to make brain plans, and what we want to take, the box that we would like to take in the end, how many of these countries, member countries of our society, do have comprehensive brain plans? Next point. Workforce. Tarun already mentioned us, and I can talk about it. I'm active in Africa myself. I started in Rwanda working with the one and first neurologist in that country for a population of 11 million people 10 years ago. Now we are 6 neurologists, and we are having a capacity building program that will allow them to have like 25 neurologists in 4 years. It's still underserved. You know how many neurologists or how many people an average neurologist has to serve in Europe? It's about 15,000 people. It's not enough. And if you look at the European Union, half of the countries have not enough neurologists. So I do not want to spoil the festivities here by rightfully saying, you know, it's wonderful, we are doing so much research, the research is wonderful. Yes, it is. It's very encouraging, it's very promising, but there's lots of work to be done. So the job is not over yet. Last but not least, what does the European neurological community do? What do we do with research? We have welcomed the wonderful efforts, among others by EBC, publishing the ZEBRA document. However, we felt that, and the neurological community and our patients feel that some of these policy documents are not concrete enough, are not really reflecting the clinical needs of the patients. And one of the most important things that, well, sometimes doctors tend to forget, what is the primum movens? What is really making us do what we do? It is the patients. I mean, what is the difference between a translational scientist and a basic scientist? Well, I think many basic scientists may be driven by the ultimate welfare of their fellow human beings, for sure, but the key point of a clinical neuroscientist the clinical driver, the main driver, is that the research is aimed at fast translation. That's really what we all want, and that's really where there still is a problem. I still believe that if we were to spend much more resources on neurological research, and more specifically translational neurological research, we would be much further. Do you know what the gap is between the high prevalence and the ratio of spending on neurological disorders? We have already said it's 1 in 3 patients, at least 1 in 3 patients. The overall average spending in European countries on neurological research is less than 10% of the entire budget. It is the same thing in universities. I'm in the Ghent University academical community, to my own frustration, and the same is true for Belgian universities, and I'm afraid it is true for many top institutions in the rest of Europe. The universities, in terms of education, are also only spending less than 10% of the resources into neurological training and neurological education. So we still have lots of issues. I see it not as pessimism, I see it not as negativism, I see it as a call for action, I see it as a challenge. Thank you very much.
Now, Orla, let's hear from you.
I had to follow all that.
Sorry.
Well, first of all, I'd like to thank Fred and the team at EBC for giving the patient voice an opportunity to join its partners here. While there are many challenges that we face, I think research is the one thing that gives so many patients hope. Although I can also tell you that we do have a grave situation across Europe for neurology patients. Only 1 in 5 have access to affordable therapeutics that satisfactorily manage their condition. So it doesn't cure it, and we also have significant issues around access, affordability and availability. So there is that challenge that we start with. If we reflect on the conversations that were held today, we do have a huge opportunity and a huge momentum behind the adoption of the IGAP. So earlier this week on Monday, EFNA launched its position paper on the first 2 targets that our community would like to prioritise. So the first is around the development of national neurological or brain health plans. So that is uniting the voice of the patient communities, of the clinicians, of the researchers to address the politicians. Now, I know, Tarun, you've said the IGAP is not a legally binding document, but you remind any politician of something that they've made a promise to and they haven't delivered on it, they're not going to like it very much, and it will make them act even just a little bit. So we have that opportunity. The second target that our position paper addresses is the need for awareness campaigns. So a national awareness campaign around at least one neurological condition. So another major issue that we have is stigma and discrimination. So we know that 92% of people living with neurological conditions across Europe live with stigma. And I think thanks to COVID, we all know what isolation is as well. Isolation is something that people with neurological conditions face every single day. So I would ask you to take some time to follow us on social media, click into our website and look at that position paper, because we're receiving requests every other week at this stage about what can we do with this global action plan. It's a huge piece, but where can we start? We also have national alliances contacting us, recognising that yes, a rising tide will lift all ships, and yes, we can act together to ring fence some funding through our governments with national neurological or brain health plans, but we need the support of the clinicians as well, because it's very much easier, if I may say so, for the head of a department in a hospital to pick up the phone to talk to the health minister than to your average Joe Soap living their everyday life trying to advocate for access to diagnosis, treatment and care. So while we have a number of challenges, there is a huge opportunity. Another opportunity is with the NCD Healthier Together initiative. So I'd ask people to also push DG Sante on this as well. Yes, we talk about neurological and mental health within that strand, but also when we talk about brain health, and I'm so delighted, Irene, that you mentioned that the brain is not only the brain, but the spinal cord and the peripheral nervous system, because we've many within the neurological community, the neurological patient community, that think that term brain health, while so potentially efficacious, is neglecting those with peripheral nervous system disorders. The advantage and opportunity that we're trying to promote and create through EFNA when we talk about brain health, so two words that are very common, probably a lot more common than the word neurology, is that it's something that people can get their head around and work towards, but it's so important that all of neurology is maintained and referred to under that umbrella. For EFNA as well, I also want to make the point, I think someone mentioned earlier that today we might be a little more focused on neurology than mental health. For many living with neurological conditions, mental health is a real issue. Over time, chronic conditions, living with any chronic condition, but particularly neurological conditions, it can lead to the development of mental health conditions as well. By contrast, or similarly, whichever way you want to look at it, people living with mental health conditions, if you're managing a mental health condition, it can also impact on how you manage your neurological condition as well. So these neurology and psychiatry are not necessarily two opposing parallel universes, but rather housed within that context of brain health for a person. You know, a person is one. So I would just like to make that point. But you know, without all of the stakeholders that we have here today, without the advances that are being made, you know, the future of everyone, as you've mentioned, of 1 in 3, and probably as time goes on, closer to 1 in 2, our future is in your hands. So keep up the good work.
Thank you so much, Orla, and very happily we do have time for questions. Now, the thing that I'm picking up on most of all is, well, we've heard repeatedly this figure 1 in 3 and the need for patients and the need for data as well. But in order to get the data, you need a diagnosis. And you said yourself you weren't diagnosed till you were 43, and that's probably not uncommon. And I'm sure there's many of us sitting in the room here, if we're 1 in 3, we don't know what conditions we have. We don't know what state our brain health is in. So how do you get the data? How do you, I'm going to turn to you, Philippe, because maybe you're on the front line of that. I mean, first of all, a person has to go to somebody, and you've mentioned the ratio of 1 to 15,000 in Europe, and that's a good ratio compared to Africa, Rwanda, for example. We don't even know who to go to. Obviously, the first practitioner would be our local doctor, and in many countries, even ones with free, in inverted commas, health services, psychiatry is not free.
Absolutely. Thank you for raising this point, because that's what we call the problem of access to care. And before getting the proper care, you need to have the proper diagnosis. So it's mainly in our rich country in Europe a question of how the GP, the general practitioner, is being trained for that. And usually the training of GP for mental health is relatively limited, couple of hours throughout 10 years of studies. So usually they're not sufficiently trained. But whatever, we are sufficiently rich to have GP, and if they are not feeling too comfortable, they can send the patient to a psychiatrist when there is one available. And there's been huge discrepancies, even in Europe, for the number and the density of psychiatrists and neurologists. We lack psychiatrists much more than we lack neurologists. That's my point of view, if you may accept. The other aspect is that definitely worldwide, the problem is incredibly incredibly heterogeneous. And as in some countries, I've been working in one country for Africa a couple of weeks, and the number of psychiatrists in France is 12,000. In this African country, it was 12 altogether for the whole country. So there's no question of having access to a psychiatrist. It's really training nurses that are being supervised by a GP, that are being supervised. So creating a network that facilitates access to care. And the last point would be when the image is very negative, it's a huge stigmate. And then they are too shy to talk about that. And then I have also other ideas of the origin of such a mental health. We burned patients before in our history in the Middle Age in Europe also. So it's very important that sharing information, increasing knowledge, sharing this information together will facilitate whatever the care that you offer to patients.
I mean, I didn't think about it in those terms, but given Elena gave us such an optimistic view, we have moved on since burning patients in the Middle Ages. That's quite an improvement, I think. Yeah. You yourself are a patient. You eloquently spoke about that, of course. And with the work that you do, with the patients that you meet, what can be done to improve those numbers going towards diagnosis? Who do you talk to try to get the metrics that are so very important?
What I believe is informing the huge population about the different aspects of diseases, for example, of conditions, of psychosocial dynamics properly, bravely, honestly, can reduce stigma, can fight stigma about mental illnesses. And for example, I think the first help should be the family and people around us, friends who are informed about conditions. And
sometimes, sorry to interrupt you, but sometimes the family are not helpful,
Surely.
and sometimes they can cause problems with brain health.
Certainly, but finally, it is the worst case when you feel totally alone at the end and you don't have anyone to talk to. For example, organizations like GAMIAN-Europe, we are there to prepare great information materials for all those who are in need about the most stigmatized mental health issues as well. And I think this work is very important because these materials, these, I don't know, easy to read materials should be reached by anyone all over the world easily. And there should be teams to prepare these materials properly together based on the needs of the patients and based on the perceptions of the patients, because I know how it started. I know what kind of stigmas I had to survive with schizophrenia. And I know the difference between normal life and abnormal life at the end, you know. So many patients in different areas should be collected, should be together to prepare the community for accepting mental health issues.
I want to turn to you, actually, Paul, because you represent University of Ghent as well, and you've mentioned, and you're not the first person to mention today, that there are not enough neurologists, and so we're talking about a pipeline system here. Therefore, we need to delve into the educational system. So it's lovely sitting here in a room with your peers, but what is being done to target younger people in order to raise that pipeline? I mean, actually, my 16-year-old has stumbled across neuroscience and is very interested in it. I'm very happy. I have had no influence on that, and I will encourage her, and I'll tell her all about today, but she stumbled across it.
Well, maybe two things. A reflection on reality. Again, a bit frustrating. Giving an example of this country, which is not really among the underdeveloped countries of Europe, I would think, the number of hours taught in neurology, clinical neurology, has diminished under my watch rather than increased. This is the same for the 8 other university hospitals and university programs in neurology in this country. And I know from the studies that we have done that in many countries it is the same. So it is like a contradiction, and apparently based on a general lack of awareness, not only with the general public, but also with academical authorities, within the field itself. Neurologists do not seem to be aware of how important they are and which important role they have to play, and how big their impact is, and how big the impact of the lack of neurologists, as a matter of fact, is. They're basically so busy trying to run the waiting lists and not thinking really about, you know, the bigger picture. That's the one thing. The other thing, And on the positive side, what we are trying to do, and this is something that we are trying to reach or to achieve on a European level, the idea would be that the best medical student, that the best students in nursing school would go for either a training as neurologists, psychiatrists will do too, I have no problem with that. And I would certainly agree with you that apart from increasing the workforce, increasing the level of the quality level of the training programs, nurse specialists and other, let's say, supportive staff that could allow or that it could increase access of individual patients to neurological care is really important. So these are positive action points that we should work on.
If I may add, not just the nurses or the various medical students, but also science students, more generally perhaps.
Clearly, but I mean, well, in that sense, I should nuance. If you look on average, and I mean, my colleague from FENS will not contradict me, the typical person who endeavors into a basic neuroscientist profile is usually among the top students. So I mean, the level, the field in itself and the content of the field...
Not the top students also.
Well, maybe that I'm not competent to comment on. But I mean, it seems that the content of what we are doing is highly attractive to bright young people. There is no question about that. But I mean, in order to make them choose for a profession that takes care of patients is another issue.
Thank you very much. You also mentioned, actually, we don't have a definition of brain health, which seems quite fundamental. You have seen a lot of papers come through. You edit every day. What would be your, sorry to put you in a position here, but what would be your definition of brain health? And I'm going to ask you the same question, Orla, so you can just prepare your answer. What would be your definition?
I think we already have a definition that has been provided by WHO. And at all effects, the definition that my journal will use for brain health will be the WHO definition. Now, that definition, we all agree that it will be difficult to operationalize because it's quite broad. So it includes multiple aspects to work on. But I don't believe we have an alternative beyond working on that and trying to accomplish that with the efforts from a multidisciplinary approach, anthropological, cultural, ethical, philosophical, and the neuroscientific basis, which will be fundamental. Yeah.
Would you like to add to this?
Yes, just very quickly, because the WHO also promoted a sentence for us, which was very important, that there's no brain health without mental health. And this aspect for us is extremely important because usually we consider, psychiatry is largely above the brain. It's also political, social, psychological education. Yes, but nevertheless, it translates into the brain. So reconcile those two aspects for psychiatrists is very important. We completely feel confident with the idea of being a brain disorder, but we like just to remind everyone that definitely it's also brain health means mental health.
Thank you.
Yeah, I think, well, but this is, I suppose, that for Paul to explain, I believe that you will refer to the biological definition of brain health.
I would like to challenge you. Go to a first year of college population, very broad, and ask a multiple choice question, what do you think brain health is? You would be negatively surprised, I can tell you. I'm predicting. And what I'm saying, there's plenty of definitions. What we really need is, and the WHO did a wonderful job by just promoting this, we need to tap on the same stone every time, over and over again. We need to speak with one voice about brain health, what is brain health, and make it sure that everybody, and you may find an operational definition for the broad public that I think could be slightly different and more simplified than the definition that the professional field is using, but we need a one-voice definition. That's what I said. I did not ignore that there was a definition. What I'm saying is that if you would ask the general public, you would be surprised.
Promised I'd come to you.
This is actually quite a controversial topic for the membership of EFNA, and I want you to realise that when I talk about the membership of EFNA, we're talking about everybody in society, if we think back to 1 in 3, so look to the person to your left, to your right, or it could be yourself. Someone here, you know, you make up the population of Europe and broader parts of the world. We had a real challenge last year when we first introduced the concept of brain health around tackling policy and advocacy issues for neurology. And a huge proportion, and I mean those representing hundreds of thousands, thought that brain health meant mental health. And if we were talking about mental health, that we weren't talking about specifically somebody's neurological condition. So we had a huge amount of work to do last year. We had an initial roundtable towards the end of the year. We're having another one on May the 4th, and it's from understanding to action. And I can tell you here and now, despite the fact that we have a lovely advanced title on that roundtable, there are still going to be tens of thousands, if not hundreds of thousands of people across Europe who, when they hear the term and read the phrase brain health, they're going to think mental health and they're not going to think neurological conditions, and specifically peripheral and nervous system disorders, people living with MS, people living with myasthenia gravis. They don't feel, unless they have a mental health issue associated with their neurological condition, that the phrase brain health refers to them. So we have a huge amount of work to do to ensure that people feel included. And that's a priority for EFNA this year, to make sure that all of neurology is included when we talk about brain health. Because the brain health momentum is happening whether we like it or not, but we need to ensure that neurology is included in that context.
Thank you, Orla. Well, the floor is yours. Have we got any? Yes, Juan. If we could just give Juan a microphone so it can be picked up by our live stream.
I'd like to comment on this issue, but because it's very important. I mean, having a good definition of brain health will help everybody to understand what we are talking about. And I'm curious about what you said, because to me, talking about brain health is more inclusive than talking about mental health. And precisely, we have been 1 year discussing at the in EBC how to, I would say, improve the definitions of brain health have, and this is extremely difficult. I mean, the conclusion is this is extremely difficult. But we have to be inclusive and to abandon the dualistic idea of mental or brain and mind, because the mental activity is a product of brain activity. So, and I think that when people heard about brain health, I think they exclude mental health because there is still the belief that mental activity and brain activity is not the same thing. So brain health is inclusive in terms that it's including psychiatry and it's including neurological diseases. There is a problem, is that what you mentioned, is the peripheral brains, the peripheral nervous system, that in the word brain is not included. And we have to find that how to do it, how to include these peripheral things. But of course, I mean, brain health is inclusive and is including both diseases or activities or whatever, and it's a global definition of what we actually are.
Thank you.
And I would like to say something else. Sorry, thank you very much for being so optimistic, Elena. Because you are putting the finger in something important, is that, believe it or not, we are progressing thanks to the that's right. So we don't have to be so negative, because there has been a great advances over the last year, product of brain research.
Thank you. Juan, you can send your microphone back to Mahmoud, and meanwhile we'll have a question from Tarun.
So not a question, since we have been talking about the definition and giving the perspective. If you look at the WHO's constitution, in 1948, it talks about physical and mental health. But if you think about its operationalization in the public sphere, in the policy, it has been only in the last 20 years or so we have been talking about. So I think I'm going to continue on Elena's optimism. Don't be, think about the time it takes for policy action to happen, and I'm glad to see that we are talking about brain health. And we may mean different things when one person talks about brain health and when other person talks about brain health. But there is still, even in those differences, there are commonalities. And I think that's extremely important. Sometimes what also happens is that as we think from a perspective of specialities, psychiatry, neurology, we forget about the importance of keeping the person in the center. You may have more than one condition. We talked about the comorbidities, and ultimately that is extremely important. Sometimes the operationalization are done for policy. So for example, non-communicable diseases. You have those 4 non-communicable diseases, 4 risk factors. Is that non-communicable disease in the precision of medicine? No, the non-communicable diseases beyond cancer, beyond cardiovascular. There is so much that goes into it. I think the one thing I would say is sometimes perfect is the enemy of good. So let's not only aim for perfection, but for that 70% policy action that is required, and we would be able to make a change. We would be able to make a difference.
When talking about brain health, when talking about cases around patient, neurologists, to number of people that they serve, and so many different things, breakthroughs in Alzheimer's, in multiple sclerosis, etc. Since we are talking about global partnerships in brain research, I like to think that it is, to some extent, largely Eurocentric, because our study population is Eurocentric itself. So the breakthroughs that we are talking about, are they really global? The truth of the matter is that I've seen the data about Africa and other places, and I'm pretty sure this applies to many other low-income countries. But the reality is that even those data, they are not accurate. I mean, in Nigeria, where I came from, we know that the infrastructure for keeping data is not existent. So a lot of the times, those estimates are basically based on people saying, I think this is this, this is that. So when we are defining, mental health, brain health, when we are talking about breakthroughs and other things like that, for the sake of global, translational, breakthroughs, I think we need to think about how we can bring in the data from under-resourced settings, because in reality, it is what is going to help us address the challenges that is even more, more advanced in the high-income countries, because by comparing those data, you are likely to discover something that can help you to make, breakthroughs in that society that is mostly more affected. So I just wanted to make this comment. Thank you.
Well, I think, Paul will pick up.
Well, thank you for bringing this up. It sounds very appealing to me, and you're absolutely and utterly correct by saying what you said. I can offer a solution, though. And the solution is, in fact, not to kind of copy the studies that have been performed in the rich West and in the US and in the Anglo-Saxon countries, but do field work in Africa itself. I can just give you a very promising, well, promising quote-unquote example. Everybody worries about which neurological disease is really the major one and has the heaviest burden in sub-Saharan Africa. It turns out to be epilepsy. The prevalence of epilepsy in the Western world is about 1%. Older studies in sub-Saharan countries from the west to the east of that areas indicated prevalences 2-3 times as high. We were facing a particular problem in one particular country, and what we did in 5 areas of that country, we did field work and basically visited in villages every person in the population. So doing really the tough, it's very time-consuming, it's enormously costly. What is the outcome? I have to be careful, it's not published yet, but it will be it will be out very soon. It's at least 5 times higher. So your point is very well taken. Many of the assumptions that are taken from Western studies in Africa are not accurate. And I mean, well, the situation is actually a little worse than we thought. So it's, again, a very strong call for action.
So really, Orla, following your point about how difficult it is to get people to not link mental health with brain health, I think it's a really important point, because we have now brainwashed people, forgiving the pun, that they are associating, because of the word health at the end of mental health, you know, that's the problem. It's a semantic problem. People are now locked in. The moment they hear health is mental health, that's the go-to phrase. So there is an opportunity to maybe rephrase it. And if you're thinking specifically about the neurological conditions, what you want is resilience to then potentially a disease beginning, and how resilient will your nervous system be? So you could go with neuroresilience, nervous system resilience. There could be another way that just changes the emphasis so that you keep mental health as mental health, and then you bring in the whole of the neuraxis, thinking more about the resilience component of the nervous system. There's probably a better way to place it, but neuroresilience. I mean, I think resilience is a word, obviously I'm English, but I think that translates reasonably well that people will understand it. So that's just a suggestion and a different way to think about it. I was really struck by your point about how unattractive, to put it a blunt way, neurology is for young training medics to come into. And I just wonder whether you could comment a bit more about two things that I've observed as maybe contributing to that. One is a gender-related issue that for women, I think there's a issue there, and that's interesting compared to other areas of medicine. And I think there's a whole raft of things that, you know, again, one could discuss and think about why it's potentially off-putting for women to go into. And then, you know, anecdotally, a lot of people say because of the frustration and not being able to cure, you are going to be, as a clinician, managing chronic disorders for the rest of your career. And that's dispiriting. So people are more attracted to areas of medicine where they know they can fix the problem. Now, of course, this will improve as we have more cures. And I just wonder what your thoughts are about those two issues that is putting people off.
Well, psychiatry be similar? You're dealing with people.
Yes, the same would. Yeah.
Well, if you allow me, thank you for raising that point. Well, I don't disagree with you, but I might look at it from a different angle. You're perfectly right that it may be let's focus on the gender issue first. Apparently, well, in many countries, the majority of medical students are female now. Still, the majority of candidates for neurology is also female, and then, after being selected, you basically, well, depending on the institution, it's typically linked to high quality outcome parameters. So you end up with a massively female staff, still. And then the problems happen because, and this is lowest evidence possible, it's my personal advice, I have not seen really compelling studies. The level of expectation of neurology, and there is where I think we disagree. Neurology used to be very conservative, used to be, how should I say, a medical specialty that was more contemplative in nature rather than active. That has completely changed. The neurology resident presently in a hospital runs around the clock. I mean, just referring to stroke units, the intensive care people have like strict diaries. They work from this hour to this hour, and they're fully occupied. Everybody knows what to expect. Young people, young medical students, young residents, when they enter the program, they're sometimes surprised, negatively surprised, by the very interactive level, the level of activity that they have to do. And this is maybe one of the reasons why burnout is so frequent among neurology residents. So I think, while I agree with your first point, I tend to disagree on the second one. It may be a difference of expectation, but the other way around.
Kindly give Philippe the microphone. Yes.
Thank you. Thank you so much for the question. It's definitely extremely important and very tricky. My point of view is that probably the European Parliament is much more interested in health rather than disorders. And resilience is connected to disorders. And because they want to promote health in order also to avoid this kind of fights between different specialists in the field where everybody says, well, my specialty is so important. So I understand the political point of view. And my idea is that we have to be clever enough in order to deal with this aspect. There is one very nice example for mental health and promoting the idea of health instead of the disorder. You know, it's very good to have a little walk in the wood, meeting trees. We all know that. That's very good for your health. But the point is, we now demonstrated that the more trees you meet, the less depressed you get. So promoting health also has an impact on disorder. And that's a good example of how we have to be clever enough in order to organize fields where everybody's concerned, where we are doing something which is good for the health of everyone, helping also to understand what's behind the scene. And my conclusion is that also in our association, we always promote it, that mind, where you have there's no brain health without mind health, but we will now add also for getting mental well-being, you need also good brain health. Thank you.
There's similar studies saying that, I have a microphone. No, thank you. There's similar studies saying that patients recover more quickly if they can see plants and they have greenery from their trees as well. So even our geographical locations matter. I fully recommend getting a dog and walking in the woods every day, if we're lucky enough to live near them. We have a question from, if you could introduce yourself, because I don't know your name.
My name is Tadeusz. I am working for the European Federation of Neurological Associations, so I'm here with Orla. So first, I just wanted to build on the discussions on the burden in the low and middle income countries. We heard from Tarun that neurological diseases, this is 70%. Mental health conditions, actually, according to the World Bank, 84% of burden falls in low and middle income countries. And then there is, of course, an issue of preventable burden, which is even much wider than these general figures. Then regarding the definition of brain health and kind of looking at mental and neurological, I think another way of looking at it is that brain health is a determinant of mental health, and we can do a lot to improve mental health through kind of looking at protective factors and how to better protect our brain. And I would say I'm not even sure if it's really possible to have a one unifying definition of brain health. In my view, it really depends on the context. So in a way, sometimes context is more important than the content. So it should be functional. And depending who we speak with, we should be then adopting the definition, because of course it will be very different when we speak to researchers and very different when we are speaking with policymakers or patients. And finally, I want to add one more voice vouching for the positivity of Elena. Thank you for this. I think we all know that there is a lot that we should be improving, but it takes an extra effort to also notice the progress. And as you, Elena, said, the progress has been absolutely tremendous in the last few centuries. Thank you.
Thank you very much. Yes, we have time for another very quick question. Well, maybe two very quick questions, and then we'll go to coffee.
Yeah, I'll be really quick. My name is Sharbani Chakraborty. I'm from Technical University Munich and working on brain health in India. And I really appreciate the discussion today, but one thing I've been noticing, especially in the context of COVID, that there's a whole informal world happening around mental health, and young people are turning to apps, online platforms. So I was just wondering, how do we bridge the scientific world and the informal world, which is also moving very fast? Thank you.
An extremely important question. I'll turn to you,
Very
Philip.
quickly on this aspect, because COVID increased by 13% the rate of mental disorder, especially for teenagers who are definitely asking for care. But the good aspect of it is that also COVID helped to get more video, Zooming type of meetings. And that's very important for those young ones that don't look like to get to a psychiatrist and so on. And they can have much easier way in order to get access to care. So we also facilitated another way of treating those young ones, but they're definitely not care. And my feeling also is that this is connected with the decreased number of the young ones now reaching these very specific training for becoming a neurologist or psychiatrist. The young ones now have been such, a large impact on their mental health, on their way they see their life. And our beautiful activities means also quite a lot of pressure because of work, because of time. And now, they have a little bit higher sense of quality of life, which is good for them, but then, well, a bit less attracted to our specialty.
Yes, Peter.
Just a sentence. I'm from a community-based psychiatric center, and COVID showed us how patients and professionals could work together to make a transition from that ugly period what we had to face, and we created a livable, nice online atmosphere, patient-based, peer support-based, and I think it is iconic because this was the time when patients could show that they are there, they can work together with the care system.
Thank you, Peter. And I think Mu Ming had a question.
Yes, just a comment. I come from China, the biggest developing country with more patients, neurological psychiatric patients than any other countries. Brain health is such important problems. I think the issue of defining what is brain health is really the problem. So we need the objective criteria, much like the psychometric measurements, but not only psychometric, but neurological, sensory, motor, all included. I'll say easy to use, accurate quantitative definition of the normal population, how they are, the normal distribution of various functions. We need large data sets so that we can define what is normal, what is abnormal.
But how would you get those data sets
Yeah,
then?
so we are introducing a simple 30 minutes health checkup, brain health checkup kit into the annual health checkup system as an option in Shanghai center, health centers. So we can collect the information of people of different ages, how they progress with time. Maybe in 5-10 years, we have a large amount of data, so we can define a normal curve. Where's the boundary? Maybe an international consensus. A normal curve above certain limits, we said this function needs care, it needs intervention. Now, I have a blood pressure, high blood pressure. I have no problem saying I have blood pressure, but I don't know. I have a blood pressure above 140/90, right? That's a quantitative criteria. Everybody agree internationally. So what about memory? I think I have a decline in memory, but I don't have a metric. I don't know. My working memory is a decline beyond normal, so that I need that. I need a normal curve to define my mental status or. No,
collaborate with some of the longevity pills that are out there now in the market.
Exactly, right. Or with intervention, I mean, if I was told by my physician that working memory is declining beyond normal, well, I'll be inclined to take prescription of mental exercise for my working memory, just like I take blood pressure pills. There's no stigma to it, right? If it's defining not as a disease, but as a function.